So you need to have the sample processing for the flow cytometry. So it's a single cell suspension is the prime requirement for the flow cytometry for any sample types. It can be a peripheral blood, it can be a bone marrow, it can be a fluid CSF, it can be a fine needle aspiration, it can be a tissue also. So you need to have the single cell suspension to have flow cytometry, done flow cytometry. It's required the specific staining with the fluorescence antibody allows assessment of the properties of the single cell in the heterogeneous populations. The brightness of the fluorescence signals correlates to the amount of bound antibodies to the antigens, nuclear DNA content or biochemical characteristics, which require the protocol fixing, like you should have standard operating protocol at your lab, even though you're copying from referring from any lab, so you should have in your lab with your setup with your reagents. That is very important things. And it helps in the diagnosis, establishing the prognosis and assisting the choice of therapies for hematological malignancy. So before you go for the sample processing, what you need before you start? So you should have the SOP protocol, standard operating protocol. Obviously, the patient sample, which is invasive procedures from the bone marrow are very precious invasive samples. All reagents validated in terms of PPS, RBS, in-house preparation, if you any. So before going for the patient sample, you should done it in the normal sample also. Cell count, as a specific cell yield. Cell count means that you should have known number of lysing volume on basis on the cell count to have the optimum sample use. Even you can restore the rest of the sample for your further studies or something like that. You're not wasting the cells to have a cell count. And obviously all necessary things like the tubes, racks, pipette, centrifuge, blah, blah, whatever is needed to have the sample processing. Water bath if required, in the case of where you require the laser resistant RBCs at the 37-degree incubation. The most important cell count, the cell count is performed to calculate the sample lysing volume. Either you are dealing with the stainless wash method, either you are dealing with the lyso stain method, bulk lyso method, doesn't matter. So number of required cell into number of tubes divided by WBC count from the analyzer and into dilution factor. It means that if you are dealing with the bone marrow, you dilute your sample, 40 microliter sample plus 160 microliter diluent and run it on the 3-part function. So approximate it will give the count. On the basis on the that count, you can find out the what sample should be used for your assay. So it can be a multiple tubes, like 5 tubes, you have the like sample volume is 300 microliter total. So you can have 60 into 5 tubes. The example is given. So in our scenario, we use the Excel sheet to avoid the manual errors. So like if somebody has to calculate for 10, 20 samples, we routinely process almost 30 to 35 samples a day, including all MRDs, these apart from the cytokine and anything. So it's very easy to calculate. You just put the cell count obtained from the 3-part counter and you will get what the basis sort panel type, how much sample you have to be lysed. So that will save your time and that will error free. So type of sample we do, the liquid is the bone marrow, then peripheral blood, the fluid is fine needle aspiration in the solid tissue also, and we work on the plasma to have the cytokine levels analyzed using the CBA assay on flow cytometers for all the interleukins, TNF, alpha, gamma, all things like that. So again, the collection of sample is very important. Choice of anticoagulant depends on the analytical methodology. The EDTA is preferred for morphology and absolute count, but sample stable is up to 48 hours. So we have tried, so it can be up to 72 hours, it can be good, but there are the some of the alteration in biomarker like CD44 because of the EDTA. So peripheral blood, bone marrow, and hemorrhagic fluids can be collected in this EDTA. Even majority of fluids, CSF also collected in EDTA along with the RPM media to restore the cell morphology even for the flow cytometry. Heparin is preferred for the flow cytometry, which stable up to 72 hours. It has again issue for the lysing of RBCs, and for the few markers also it is alterated. Fluids can be sent in the plain tubes or contains RPMI media. In our scenario, what we do, we add RPMI, complete RPMI media in EDT tubes and send it to the OT. They will collect the CSFs basically because it's a polycellular material and they get viability, they degenerated very easily and very less time. To restore the things, we add the RPMI media in EDTA, send it to the OT, and they send the sample to us. Tissue samples are sent soaked in a saline, but best is RPMI media or even PBS for the shorter time. But if you want to preserve for longer time, it should be the complete media. Only thing the care should be taken, you should not use the fixative for this tissue sample or FNA because you are losing your phenotyping. Some of the markers will not work once they get fixed. There are methods, different methods of sample processing. It can be a light stain wash. That means you are lysing the sample first. So it has two aspects basically. One is lysostain and bulk lysostain. So lysostain and bulk lysostain, the difference between that, you have 5 tubes of panel in a leukemia. So you will lyse individually for the different 5 tubes. That means the lysostain. That individual sample volume to individual panel tubes like L1, L2, L3, L4, 5. Bulk labs, you will bulkly commonly prepare the cells first for the required for the 5 tubes. So 50 microliter per tube, maybe that is into 5, it becomes 250. So then you divide it. So it will only assure that there is no variation in the cell number if you are going with the bulk lysostain. Because in lysostain, it may end up with the some of the clumping to particular tube, clumping, not the clumping in a particular tubes. That can be because of static adherence of the Falcon tubes, plastic tubes. That again, one of the factor. So majority time the light stain was preferred for leukemia, lymphoma, phenotyping, MRD also, but not preferred for the bead-based quantitative assay. Stainless, no wash is preferably quantitative assays. Bead-based, basically you can say CD34 enumeration count. You can go for the CD48 count. So you can have count tubes. You add the stain, the whole blood, whole blood. Then you can put markers as per your things because we to do CD48, so you have 10 markers. CD34, 45 is only 2 markers, and say along with the 780, it can be done. Many people do stainless wash for the leukemia, lymphoma also. No wash basically because you don't want to lose the bead. Stainless wash also can be used for the immunophenotyping assay, but in case of where the MRD, where you are going to acquire the 5 million cells, so it's difficult to count the lysing volume, like basically the quantity of the sample. In very low count, it might go up to the 5.5 ml to 1 ml. So it's very difficult to add that. So that's why it's easy to on the phenotyping. So basically you must have, I'm not going into detail because I have the protocol in my last slide. So I'm just discussing what exactly sample processing means. Sample processing means the lysing of the sample. Then once you prepare a cell palette, you get the cell number of cell, required number of cells. Then you're going to add the antibody. Once that antibody is done, then you're going to wash it and then finally it's ready for your acquisition. That is about the surface staining. So there are many lysing reagents are available. So only thing you have to make sure that while dealing with the lysing reagents, so there are types of lysing with and without fixative. So if you are going for the bulk lyse wash method, you can use only RBC lysing without fixative. That is preferable. If you are going for the stain lyse wash method, is already preferred that you can use both lysing reagents for your staining. Because post-fixation staining will alter your results even after antigen expression for the particular different assay. Assay to assay difference. So out of these, you can see that there are list of on left hand side. Faxlyse has a fixative. Optilyse has a fixative. Farmlyse is ammonium chloride base. Again, that is without fixative. The even Versalyse and EL buffer also without fixative. So everybody knows the lysing agent is used to lyse the RBC lysing buffer. The main principle subject to RBC to a hypotonic solution relates to lysis and influxes which break the cell membrane of the RBCs and they get released in this end will get rid of the things with the help of the washing. So we use the in-house RBC lysing, that is ammonium chloride base. The third method, you can use the phycol-hypic separation. The red cells, granulocytes, and mononuclear cells can be get rid of the bottom. We're using the 1077 gradient hypic solution, that is specific gravity solution. You can see on the left-hand side, only thing you have to make sure that always use the blood that is diluted. That is one part of blood should be diluted with diluent like the PBS things. Then water you are getting your sample, diluted sample. So one part of phycol with the two part of blood sample has to be used. Then you will get the proper WBC layer, that is a Buffy coat layer. Using the Buffy coat, you can see upon the plasma. Then the middle layer is you can see the WBC. Then on lower is RBCs, and because the granulocytes lose their things, they will again come to the with the RBCs. So will whatever you once you get the phycol, you will get the mononuclear cells. So you will end up with the without neutrophil, without granulocytes, you are getting the cells. So second part is the staining. The staining has a surface staining as well as the cytoplasmic staining. So staining procedure. So just we'll go back for this lysing. So if anybody has a questions about the what centrifugal speed should be there. So it's a 540 G once you for the lysing, once you have to spin it after lysing, after any wash. When I say wash, you have to add PBS and you have to centrifuge it for. So that is for the either 2 or 3 minutes depending on the time. So that has to be set according to a lab. You can refer again. So for 5 ml tube, we use the 2 minutes wash, like spin at the 540 G. And like tubes like 15 ml or 50 ml, it should be 4 minutes to 5 minutes. Otherwise you will lose the cells. Second part of this sample processing is the staining. So surface staining, it consists of staining the antigens present on the surface of the cell. The cells are incubated with the antibody and washed to take the unbound antibodies. Basically, wash means previous wash to stop the reaction, antibody-anti-reaction. So compared to this process, surface is a easier process because it's one-step procedure. So there are, and next step is a cytoplasmic processing. For cytoplasmic processing, you need to dissolve the layer of lipids of the surface, that cell surface, with the help of this permeabilization reagent, and then your antibody is going to bind with the cytoplasm. There are available fixed form thermofisher from A and B, then Fox P3 buffer, Paxlyze also can be used. So we are using Paxlyze as a fixed form for our Cas67 assay, even for the GATA3. Intraprep from Beckman-Coulter for fixed NC is a no centrifuge method again from the Beckman-Coulter, and true nuclear transcription buffer. So we have a different assay as we are standardized as per the their expression for particular cytoplasmic and nuclear diets, like TDT. So it require different time. So that has to be again set. So third step is comes under the cytoplasmic staining. So like you have the lineage specific marker like anti-MPO that has to be processed cytoplasmic, anti-MPO, cyto-CD17 alpha, cyto-CD3 in TLL basically. Then apart from that, you have Cas67. We are doing NPM1 also, TDT also. We are dealing with some different cytoplasmic marker. For that, you need a fixation and permeabilization. So this is again going to happen like two steps. So again, you should consider while cell count, you consider the 50% cell loss or additional loss. So you should have more sample when you dilute or when you lyse the sample, if you have the cytoplasmic staining. So, and the most important thing, the concentration of the cell. The standard concentration of cell taken for immunophenotyping is 0.5 to 0.5 to 1 million cell per tube. Ultimately, it depends on how much you are going to acquire. So as standards, 2% of cell of interest can be defined. So we acquire for leukemia, lymphoma is a 1 lakh events per tube. For detection of rare number of cells, for example, MRD, so we do 3 to 5 million. So basically 5 million cells for the all BMRD, TMRD, MLMRD, even myeloma MRD, and for MLMRD, we do the 2 million cells. Cell counter as well as flow cytometer can be used at just the required concentration. Hematocytometer can be used. So that is basically nowadays nobody is doing. Everybody has a three-part counter. So you end up with if you are like not sure that this going to like MRD, the cell concentration is not enough. So you can always check the count, and then if you want to realize the sample, you can realize the sample again, repeat the lines, and then go for the cell suspension. So viability is also important issue. When you're getting the sample, maybe the in-house sample, you are getting the outside sample. Basically, in-house sample doesn't get affected for the viability. So it can be checked with the 7AD. That is easy. The previously the DNA quantification also is doing by the PA, but nowadays going doing the effect cycle violet stain from the thermofisher. For FNA, like fine needle aspiration, difficult to take a cell count and rely on the cell count. Getting from the flow cyt or the getting from the CBC analyzer, it easy to do it on the flow cytometer. So what you have to take, whatever the sample you are receiving for the you have tube 1, tube 2, whatever the sample receive, use 10 microdrop sample, put some lysine, and after 5 minutes or 7 minutes of incubation, run it on the flow cytometer. So here you can say on the right hand side top you have used the CD45 also, because you will get in FNA you will get majority of cell epithelial cells, so many non-specific cells apart from your population of interest. So to get rid of, you can have the CD45 cells. So in this, we can say the viable cells, because these viable cells are getting on CD45 WBC. So viable cells here are 366822. Sample volume you use the 10 microliter and cell count is 3668 per microliter. So if you rely on the counter, you will not get the cell yield as per your expectation. So that's why it's easy to do the FNA cell count on the for these particular samples like final aspiration on the flow cytometer. It's very good. Even in the tissue sample, you can take a cell count on the flow cytometer. This is just an example. We can say here the CD45 WBCs are getting is a 9842. Sample volume used was 10 microliter, and that's what the count is 98.42. In the case of tissue, you can see here, tissue can be used, but only thing, once again, I will just want to remind, it should not be fixative. Fixation, like it should not be in Bowen serum, it should not be formaldehyde. Otherwise, you can't do the flow cytometry, you are losing on the antigen expression. Even we have seen that CD45 doesn't work with the fixed cells or the fixed tissue. So tissue, there are available. So in our hospital, we have tissue dissociation from the BD, that is tissue homogenizer. So we use as like you have to put the cut tissues, put it in that particular given the module, just spin it and it will release the WBC that can be aspirated in the tubes. The best method, apart from this, those who do not have this tissue homogenizer or tissue dissociation, they can simply take a Petri dish. Actually, unfortunately, do not have the photograph, it got corrupted. You can simply take the Petri dish, you can put the PBS, you can take the mesh, that is T mesh, you can take, put the tissue and just tease it. So all your WBCs or interested cells, cell of interest will get released, and whatever you are getting suspension of the media, that can be centrifuge and again go for the staining. So when you dealing with the sample processing, what should be the sample rejection criteria? In context of flow, it might happen in context of CBC or something that you cannot take a wrong container, you cannot take clotted sample because that is robust for the generate the results like CBC, like parameter like hemoglobin, WBC count, platelet. But in flow, only rejection criteria is wrongly labeled or does not have a label. Otherwise, we do process the sample at any condition, even though it's a partially or fully clot, you can mention if you are not getting the number of cell or cell of interest, but still you can process because whatever the clot or things that could be RBC, but you can still get your WBC release from that, whatever the sample left over. Clotted samples, you can mention it on the report, and even hemolyte sample can be processed for the flow cytometry. Sample storage again is an important thing. So if you want to restore your sample for next day processing or something, so there can be sample can be stored in ambient temperature also. If not processed 24 hours, media is added like on the Saturdays or on Fridays, we do added the complete media to the sample and keep in the fridge at 2 to 4 degrees. And you can do day after tomorrow, third day, you can still process the sample to get the viability and the expected results. Some assay require immediate processing like CD34 count should be processed in 2 hours. The reporting should be done in 4 hours to have the patient is waiting for the CD34 count to be expedite for the harvest as well as for the patient's transfusion. Some of the certain in nutrition diagnostic says the bees like cells dies quickly, like Burkitt's lymphoma, probably because of proliferation that has to be processed quickly. So without delaying. Sample should never be frozen in the freezer in context of flow cytometry. So this is all the protocol is the cell preparation. So this is the whole protocol. I think this has been already shared with you. You can take a photograph if you want to take a photograph. There are the different steps, like many steps shown here. Yeah, so this was protocol was shared with you before. Thank you so much. So we can, if you have any questions, we can go for it.